Thinking Aloud. Conversations on the leading edge of knowledge and discovery with psychologist Jeffrey Mishlove.
Hello and welcome. I'm Jeffrey Mishlove. Today we are going to explore the nature of mental illness. With me is Dr. Harris Whitfield, who is a board-certified internist who transitioned into psychiatry. He is the author of the bestseller, Healing the Child Within, and many other books, including The Truth About Mental Illness, The Truth About Depression, Not Crazy, You May Not Be Mentally Ill, and co-authored with his wife, Barbara Harris Whitfield, The Power of Humility. Welcome, Charles. Or shall I call you Charlie?
Either way.
It's a pleasure to be with you. As a medical doctor and a psychiatrist, you're part of a profession that is in the habit of prescribing a lot of drugs for people who get labeled as mentally ill. And I gather that the thrust of your work is to look for alternatives whenever possible to drug treatment.
Yes, it is. Because what I've found over the decades, practicing medicine and then finally psychiatry since the late 70s, I've found that most people don't have a specific subcategory of mental illness that get labeled, mislabeled usually, as mentally ill with depression or whatever label it might be. Most people have post-traumatic stress disorder, and the more disturbed people, the more people who have difficulty in their life have what's called complex PTSD.
Mm-hmm. Complex PTSD meaning multiple diagnoses?
They commonly have multiple diagnoses as well, but the complex means they were traumatized more than the other people who have PTSD, and they are often mislabeled as schizophrenic, etc.
Now, we usually think of PTSD having to do with soldiers coming back from combat. You're suggesting other causes.
Yeah, I think worldwide, by far, the most common cause of PTSD is not a combat experience, but growing up in a crazy, traumatic family and a crazy world.
Mm-hmm. Well, that is probably most people right there. Now, PTSD, for our viewers who may not know, is post-traumatic stress disorder.
Yes.
Yeah. It's considered a disorder, but I think what you're suggesting is that it's very normal for people to who have suffered trauma to have a reaction to that trauma.
And that reaction is a normal, healthy reaction to a abnormal, traumatic, painful experience. And so they are not to be blamed, but are just to be observed, and let's find out what this is all about, what really happened.
So, I mean, the nature-nurture debate has been going on in the mental health field probably forever. And I guess what you're suggesting is that there's a lot more nurture to be considered than nature.
Far more nurture. That's actually unhealthy nurture.
Unhealthy nurture.
Than being genetically transmitted. J. Joseph and a few others have written about this extensively, highly documented, how this whole idea of genetic transmission of mental illness is really not very accurate. And I expand that in several of my books that you've already mentioned, including Not Crazy, The Truth About Mental Illness.
Well, let's go into some detail around that. I understand that many of the studies that support the genetic interpretation of mental illness have to do with twins.
They do, but the one thing throughout most of these academic research studies about mental illness is they almost never control for trauma. Therefore, they're not going to pick it up.
I see.
What they find is all these findings and connections that they say are therefore inherited. Well, if you go back 3 generations, it goes from grandparents to parents and now to the next generation who are now labeled mentally ill. Well, it turns out that the grandparents traumatized the parents who then traumatized this generation, and nobody has controlled for that.
I see. So if you have identical twins raised in separate families, there's still a probability that each family traumatized the twin in one way or another.
Yes.
Okay. What about the argument that I've seen in some literature that if you suffer a trauma, that can actually affect or activate certain genes, that our genes are actually modified by traumatic
and
experience.
That's the whole term epigenetics, where these two, nature and nurture, interact.
Yes. So you're not denying that the genetics gets involved here.
Yes, correct.
But what you're suggesting is that drugs, even if your genes have been activated by a traumatic experience, drugs may not be the best remedy.
Yeah, the drugs overall, the most psychiatric drugs over the last few decades have proven not to work well. That's why psychiatrists and physicians and other people in the mental health field continue to try drug after drug after drug, hoping to find the one that's going to hit it right. Well, that right hit may happen 1 out of 5 times, 1 out of 10 times. Based on many of our experiences, patients come in with a laundry list of drugs. But they give temporary relief. So an antidepressant may give relief for a few months, and then it stops working, and so they have to try another one.
Yeah.
The big problem here is when you stop an antidepressant or an antipsychotic or any of these psych drugs, there's a withdrawal syndrome that the drug industry does not want to talk about. Psychiatry doesn't want to talk about it. They don't look for it. They don't control for it in their studies. And so the withdrawal syndrome makes people crazier because they've stopped the drug. It's like when you withdraw from alcohol or painkillers or whatever your classical drug that we know about is. And so now what we've got is a person who's stopped their drug or has been missing doses, and they appear to be crazier, so they get mislabeled. Instead of depressed, now they're bipolar, etc. And it just goes on. And the drugs actually, in the long run, make people crazier so often.
In other words, the drugs have 2 kinds of side effects. One, when you start taking the drug, the side effects of the drugs, and then if you decide the drug isn't helping and you withdraw from the drug, you get another set of side effects.
Yes. And it's too bad because most physicians, certainly most physicians, and too many psychiatrists don't review for that and say, well, wait a minute, when did you stop the drug? Which drug did you stop, etc.? And what happened? And really you have to be off of any psychoactive drug for a few months to know really what the base state of the person's mental health is.
Well, when you treat patients who are suffering, let's say, from depression, how do you approach it? Do you try to do it without drugs at all?
Well, the first thing I want to know is, what do you mean by depression? People have different views of what depression is.
Yeah.
And so I say, tell me about what depression means to you in your experience. And so they'll start to tell me.
Yeah.
And often they don't know what to say. They'll just say, oh, well, I'm just not having a good life. I don't have a good outlook on my life, or I'm anxious, or I'm this or that.
But major depression is more like a person can't get out of bed.
That's the extreme end of it. But what I find is commonly, as we discuss in the clinical setting now, one-to-one, the patient really has low energy, low motivation, and they're scared all the time, and they have difficulty in their relationships. Well, that's not an isolated disease that they could call depression.
Yeah.
That's a trauma effect. That's a big trauma effect.
I see. So dealing with a trauma effect, I know you've written the book Healing the Child Within. I suppose this is your main approach to dealing with trauma, is to uncover the innocent person that was once there.
Correct. And back in the early 70s, I didn't believe that. I didn't believe any of that. I thought that people were making it up. The whole idea of psychoanalysis, to go through psychoanalysis, you really had to make up a lot of this stuff. And it took me a while to find that out by kind of rubbing elbows with my psychiatry colleagues in the Department of Psychiatry, where I was teaching about alcoholism and drug abuse, and then doing individual and finally group psychotherapy in the late 70s. Then I started to figure it all out. And then in the early 80s, when the recovery movement began, where there were a lot of speakers and followers in the whole mental health field that were outside of conventional psychiatry, saying, what could be really behind all of this? And it turned out to be childhood and then subsequent trauma in the rest of their life.
Well, since you mentioned alcohol and drug abuse, that becomes a complicating factor as well. Many people begin to self-medicate.
Correct. And that's universal across the world, because alcohol is a sedative that takes away our pain. The first drink or two give us energy, and then progressively, the more we drink, the more sedated we get. But then there are other kinds of drugs that we can use, from street drugs of all sorts, uppers, and then downers. You can buy downers on the street, and then marijuana, etc. So people are looking for ways to lessen their emotional and to a degree physical pain for all of this.
So you get a lot of people who have suffered from trauma who then become substance abusers.
Yes. As a matter of fact, it's rare for me to find an alcoholic or a other chemical dependent patient of mine who's not a trauma survivor.
But isn't it the case that there's a genetic component to whether or not you're going to become hooked on a particular drug? I know for myself, for example, I went through phases of my life where I was probably a heavy drinker. I grew up in Wisconsin, where it was almost your patriotic duty to get drunk on beer on the weekends. But I never developed a dependency on alcohol, even though I was a heavy user at times. These days I hardly use it at all, and I never felt the loss of it. Other people might have one drink and then that's it. They're addicted.
And from the first drink, some people become alcoholic, and they know that. And in their stories in AA or Narcotics Anonymous, they identify that.
Yeah. Well, are you more likely to become addicted if you've had trauma in your past, or do you think it's genetic?
I think it's trauma-related more than genetic. As we go back to the first sequence that we described in this session, we got to go back at least 3 generations: grandparents, parents, and now this generation. And if you say, well, my grandparents were alcoholic, and my parents were alcoholic, and now I'm alcoholic, it's got to be genetically transmitted. But what's not controlled for in nearly every study is trauma.
Mm-hmm. Do you find, working with people that, let's say the inner child work that you do, that it's possible to have a successful psychotherapeutic outcome without the use of any drugs?
You know, most people have tried their own sequence of drugs from all the ones we've just mentioned, from the legally prescribed ones to the street drugs, etc., and then alcohol. But to recover, drugs can be an aid, especially early on. And the two most common drugs that I've found helpful for is buspirone for fear and anxiety, and then for sleep, clonidine, which is a blood pressure drug that helps people sleep. And a third of the population don't sleep well.
They're suffering from sleep disorders.
They're frequently waking up at 3 a.m. worrying about things. And if you don't get at least 7 hours a night, then you're going to have a difficult day the next day. And if that happens over and over, then that can bring up symptoms of all kinds of mental and physical nature, and then they get mislabeled as mentally ill or physically ill or both.
So basically what you're suggesting is that a very high proportion of people who are identified as mentally ill are not really mentally ill at all. They're having a normal reaction to some sort of earlier traumatic experience.
Yes.
And even people who have sleep disorders may be, it's really related to an earlier traumatic experience.
Probably most of those people with sleep disorders.
But don't you also find that just as people go through drug after drug after drug without a successful result in the long run, many people go from one therapist to another therapist, try every mode of group psychotherapy and talk therapy, and also are not getting the result they're seeking?
Yeah. So, you know, it's like all of medicine is similar to all of life, or most of life. It's trial and error. We've just got to say, well, what's going to work here? And most of our often trauma-related shame and all our other pain, like anxiety, etc., who or what are we going to find that rings true for us right now, for me to identify what's real for me and what I can do to help heal my pain.
Now, I understand from your work that, realistically speaking, a person who has suffered a major trauma may require many, many years, maybe decades, to work through.
Correct.
It's people in our day and age are expecting, I guess it's why pills are so popular, it's the idea of an instant cure.
Yeah, the magic bullet. So rather than saying that I'm bad and I've done all these bad things or all these conflicts I'm in, if we reframe them as A Course in Miracles suggests, and many other people, psychospiritual seekers have suggested, that we reframe them simply as mistakes. And when we reframe it as a mistake, now we can not beat ourselves up and just now say, well, what can I do to correct this mistake? How can I help myself not make this same mistake again?
One of the problems with the whole field of mental illness is the stigma associated with the label.
Yes.
It's almost compounds the original problem when you have to say, yes, I'm in treatment, I'm seeing a psychiatrist, I've been labeled as having this or that mental disorder. It's like somehow your self-esteem is damaged by the very process of seeking help.
And that's what we call shame. Shame is a major factor, a major dynamic in trauma and healing. The way we heal shame is to share it with safe people. And that's why self-help groups, 12-step programs from AA to NA to alcoholics, adult children of alcoholics, Codependence Anonymous, Emotions Anonymous, all of these, what we do is we share our story. And our story has 3 parts. Each story, what we were like, what happened, and what we're like now. And when others in the group that we're sharing our story with hear that, and they don't get up and walk out of the room, and they don't roll their eyes, and they don't try to shame or embarrass us in any other way, I say, oh, maybe I'm okay.
Yeah.
Nobody has rejected me.
So you are an advocate of self-help programs.
Yes, yes. Along with reading about it, what can we learn from the literature, which we have called bibliotherapy, meditation, which is really observer self-training, and then learning about the difference between our real self and our false self, which I have addressed in some detail in Healing the Child Within and all my other books.
You regard the child within, that innocent being, as the authentic real self.
Right. As opposed to our false self or ego, which is who we pretend to be, and really has been a great helper in our early life for survival, for our survival, because if I didn't feel safe, I may have needed to be, to a degree, in varying degrees, false. That helped me survive, because when I was real, I got beaten up in various ways. And so I learned quickly not to be real. And then my parents and grandparents and all the circle of people around me have taught me, by modeling it, they're not being real either. And what we're doing different with some of our grandchildren now is not shaming them, not judging them, not toxic teasing them, but being real with them and nurturing and loving with them. And they're growing up able to be real.
And I gather that a big thrust of the psychotherapeutic work you do is helping people to unlearn all of these patterns and habits that result in the false self.
Correct.
Which can be a shorter or longer process depending on how deeply entrenched those patterns are.
Yes. And it can take years. We've got therapy group members now that have been in our group for a number of years, and they keep coming back because they get benefit. And what they're doing is they're each sharing their stuff, their conflicts with the other members, and then they get feedback. In 12-step groups, there's no immediate feedback because there's no crosstalk in those groups. But where you get feedback in 12-step groups, where there's no crosstalk, is you get visual, facial expressions, laughter, positive laughter, supportive laughter, laughing with somebody, not laughing at somebody. And then after the group, feedback, direct verbal feedback, saying, yes, that happened to me too. And
one-on-one.
Yes, one-on-one after the 12-step meeting.
I see. Or with a sponsor, perhaps.
Yes.
Well, and I know you mentioned the Course in Miracles, that you believe that the spiritual component is very important as well in this process.
Oh, no question. And I was an atheist up until probably my late 30s. I started meditating, and one day I just woke up to my spiritual nature in varying degrees. I didn't know what real prayer was. I discovered how to pray, etc. I grew up in a conventional Protestant family and time in churches, but then I became atheist, gradually became atheist, because I got more and more discouraged my own crazy family and crazy world. I said, a God can't allow this to happen.
Yeah.
So I just became so discouraged that I became atheist. I said, there is no God.
I think a lot of people feel that way when you look out at all of the trauma in the world as a whole, and especially trauma inflicted on innocent children and other innocent people. It's hard to believe that a God would allow this on the one hand, and on the other hand, it doesn't seem to be that God is causing it. It seems to be that people generally cause it.
Yeah, nearly always.
So if I were to sum up your view of mental illness, it seems as if you're saying that what we label as mental illness, for the most part, isn't an illness at all, doesn't belong in a medical model, belongs in more of an educational model or even a spiritual model, but that the medical model is wrong in so many ways.
The conventional medical model. But there's also a perhaps newer medical model, which I participated in with the Adverse Childhood Experiences study that came from the CDC that I helped them with some 8 papers that we published, and now there's some 40 papers out of that, and that almost all of these mental illnesses and many physical illnesses come back highly statistically correlated in a stair-step fashion with repeated childhood trauma.
And CDC being Centers for Disease Control.
The Centers for Disease Control and Prevention.
I see. Okay. Dr. Charles Whitfield, thank you so much for sharing this half hour with me. It's been enlightening to learn your perspective.
Thank you.
And thank you for being with us.